everyone, welcome back to E.L.V.A Nursing YouTube channel. My name is Esther Filippo Daily once again, but you can call me Esther Love. And today we are still in our endocrine series. We're going to be talking about diabetes insipidus and SIADH. We started talking about the pituitary gland in our previous video. If you haven't seen it, go check it out. You will love it. All right, on acromegaly, gigantism, and dwarfism. It's the same pituitary gland that also regulates the hormone responsible for causing either DHI or SIADH. I gave us this breakdown in our last video. The pituitary gland has two lobes. The front one is the anterior pituitary gland. The second one at the back is the posterior pituitary gland. And I told us that the anterior pituitary gland secretes these 5 hormones, and we looked at the growth hormone that was responsible for acromegaly, gigantism, and dwarfism in the last video. Once again, check that out. But today, we're focusing on the posterior pituitary gland because it secretes our anti-diuretic hormone, ADH for short, also known as vasopressin. It also secretes our oxytocin. However, the one that we're interested in today is the ADH, the anti-diuretic hormone. So let's dive into this fellow. The anti-diuretic hormone ADH, also known as vasopressin. What does it do? What does it do? What does it do? Now, you probably think that when you go into the bathroom to pee, to void, you just think that your kidney does all that work. It does, but something tells your kidney what to do to an extent. All right. When your kidney makes its urine, the kidney by itself doesn't know whether it should push out all the urine that it makes or to pull back some water into the body. So the anti-diuretic hormone is what regulates the reabsorption of water back into your body by the kidney. All right. So it lets the kidney knows that, hey, you can't leave us dry. You can't pull out all the water from the body. All right. So put back some water into the body and then let the rest of that be the urine. Okay. So this hormone is good for you. If not, you'll be dry, because the kidney is just going to be pulling out all your fluids, which is not good. Now, I want you to understand this, right? We are quite familiar with diuretics. Like when we think about diuretics, you say, oh, the water pill. We call it the water pill because it literally pulls out all the water. You're going to be peeing a lot. Yeah, so pretty much the diuretics, your Lasix, aka your furosemide, your thiazide, and all of the rest, what they do, they're called diuretics. They help your kidney pull out all that excess fluid from your body. So you end up having a lot of urine, also known as polyuria. Now, there's a very huge similarity between the diuretics and anti-diuretics. See, this one is called anti. Your diuretics pull out water. Your anti-diuretic hormone, they do the opposite. They tell your kidney to hold back from pulling out too much water. So you can just have normal urine quantity, not having too little and not having too much. Okay? So I hope that helps you understand the anti-diuretics. So if you ever forget what this hormone does, just think about your diuretics. My diuretics help me put out too much. My anti-diuretics, they tell my kidney to regulate. They do opposite of what my diuretics do. Now, here is a quick overview. My posterior pituitary gland is the gland responsible for secreting the anti-diuretic hormone, also known as the vasopressin, when it is secreting too much. Because we won't be talking about endocrine problems if our hormones just do what they're supposed to do and they don't do too much or too little. Endocrine disorder problems is when they're doing too much or when they're doing too little. Okay? So here we've said that anti-diuretic hormone helps my kidney to know when to pull out just enough amount of water back into the body so that I can have a good normal amount of urine. Now, sometimes we secrete too much anti-diuretic hormone, and that is what we call syndrome of inappropriate anti-diuretic hormone. Inappropriate, too much. All right, we simply call that SIADH. Now, sometimes ADH is also secreted too little, and we'll call that diabetes insipidus, also known as DI. Now, this is not to ever be confused with diabetes mellitus. Two different things. All right, diabetes mellitus has to do with blood sugar, insulin, pancreas, a totally different organ. Diabetes insipidus has to do with your ADH, your brain, posterior pituitary gland, the kidney. Do you see how different they are? Yes. All right. Now, a quick overview. Diabetes insipidus, DI, is when I underproduce ADH. Okay, remember my antidiuretic hormone is what tells my kidney how much water to pull back. Now, if I underproduce that, what do you think the kidney is going to do? Now, there's not enough hormone telling it what to pull back, so the kidney is just going to let it go. It's now going to be acting like it's under the action of a diuretic. So the kidney will not reabsorb the water back into my body. It's going to be pulling it out a lot. So I always say, like, think of diabetes insipidus. D stands for diuretics. All right. It's almost as if the person is on a diuretic and they're just pulling out because we don't have enough anti. Instead, it's working like they're on a diuretic. Okay. Now, syndrome of inappropriate antidiuretic hormone, SIADH, is overproduction of ADH. Once again, my ADH hormone is what tells my kidney to pull back water. Imagine when I produce too much of it. Now it's going to tell my kidney to pull all the water back into my body. So I end up having too much water in my body and very tiny itty bitty of urine. Okay? That's the main problem here, guys. If you understand this, if you have it down packed, it will make it easier when we talk about the symptoms that you will see in this situation and how to treat it, which is what we're going to be looking at next. Before we go on, I just want to give you another tips to remember your diabetes insipidus. So it is DI, D for diuretics, D for dehydration, because when I'm on a diuretic, I'm putting out a lot of water and I'm going to end up being dehydrated because my ADH level is too low. All right. DI also stands for dry inside. All right. I'm dehydrated. I'm dry on the inside because I'm wasting all my water because there's not enough ADH to tell my kidney to hold on to some water. SIADH, on the other hand, S stands for saturated. All right. I'm not dehydrated like DI. I'm saturated with water. All right. Because this time, too much ADH is telling my kidney to hold on to water. So I end up being saturated with water. Again, SI means soaked inside. I'm saturated with water, so I'm soaked up with water on the inside. All right. Now let's break down and compare these two side by side. It's always easier to look at DI and SIADH on the same side by side so you can just see how the symptoms change. Once again, DI is underproduction of ADH. My kidney is not pulling back water into my body. SIADH is overproduction of ADH. My kidney is pulling back too much water into my body. So because with DI, my kidney is not pulling back a lot of water, I'm going to be peeing everything out. So I'm going to have a lot of polyuria. Polyuria. Urea is urine. Poly, too much. Many. Polyuria. So I'm peeing a lot. Nocturia is too much excessive peeing at night. So this excessive urination doesn't just end during the day when you have diabetes insipidus. At night, you're still peeing a lot. So when you're urinating at night, we're now calling no. Again, so I'm losing a lot of fluid, aka dehydration. On the other hand, with SIADH, I'm holding on to all the water inside my body. So my urine is very little. We call that oliguria. All right, because I'm saturated, I'm too excessively hydrated, fluid excess in the body. With diabetes insipidus, because I'm losing all this water from my body, I end up in a hypernatremia situation. So the sodium level in my body goes up because it's like putting salt and water. It's like I have a salt in a bowl and I pour a lot of water inside of it, what does that do? It dilutes the salt. But the moment I drain all that water out, which is what's happening with DI, like all the water is going out, now I have a lot of salt, which is pretty much that hyponatremia. The opposite is in SIADH. I have my salt, but I pour a lot of water inside. I dilute it. So I have hyponatremia because, again, with SIADH, this patient is swollen up with water. They are soaked inside. They are saturated with water. So they end up diluting their sodium. With DI, because I'm peeing a lot, all the water in my body is going out. I'm also going to be very thirsty because naturally your body's going to be like, hey, give us water. We're dry. We're dry now. So you want to keep drinking and drinking and drinking. So we'll call that polydipsia. You're thirsty, so you keep drinking, which ends up, again, because you are also peeing a lot, the kind of urine you're urinating is very diluted. It's just like someone drinking a lot of water in a day. Your urine is super diluted because as the water goes in, it just comes out. It's like you're having all this very diluted urine. So your specific gravity is going to be less than 1.003. Normal urine specific gravity is 1.003 to 1.030. However, when you have diluted urine, the specific gravity is going to be low. So it's even less than 1.003. The opposite is happening in SIADH. This time around, my urine is concentrated. Okay. So I will have a high urine specific gravity, which is greater than 1.030. Another thing that is happening with diabetes insipidus, because I'm losing so much water, one of the biggest things that gets affected by the amount of water or volume in your body is your blood pressure. All right. I will always tell my students that blood pressure goes in the direction of your blood volume, of the volume in your body. You have a lot of fluids in your body, you will have hypertension. You have little, you will have hypotension. So blood pressure fluctuates based on the amount of volume you've got going on in your body. So with this patient who has diabetes insipidus and they're losing a lot of fluid and volume, they will have hypotension. You got it. All right. And this hypotension is worse when they start to change position. So we'll call it postural. So when they try to get up, the blood pressure kind of like, oh, they get that dizzy, woozy, like sit back down. Okay. And because they keep losing volume, they might eventually go into an hypovolemic shock. And the classic symptoms in hypovolemic shock is low BP, high pulse, high respiration. Aside from that, this patient is just dry. Their mucous membrane is dry. Their lips are dry. Their skin turgor is dry. They're weak. They're lethargic. They're tired because all this fluid keeps coming out of them because they don't have enough ADH. The opposite is happening on the side. They will have hypertension instead because, again, blood pressure goes in the direction of my volume. So if I have SIADH and I have a lot of water inside of me, my blood pressure will be high. Good. This patient is also at risk for a lot of seizures. I always say that S in SIADH also stands for seizure. S for seizures. Yes, your patient who has SIADH is at risk for big seizures, which means what? You got to implement seizure precautions. You got to pad those bedside rails. You got to make sure there's suction, there's oxygen. All right, you're ready to go. If they do have a seizure, you put them on their left side. Nothing goes in the mouth. And of course, if the physician orders an anti-seizure medication to prevent this, make sure you give it to them. All right. Nausea and vomiting is another thing that they would have. And eventually, as the volume increases and increases and increases, if we don't fix this on time, the fluid is going to go to the brain and they might have cerebral edema too, which is why it's a late sign. This is not something that happens like right away because first of all, the fluid is going to try to fill up all the spaces like your abdomen, your legs, but eventually it can also start to pocket itself in the brain. Now, enough about all that. All right, that's really all you need to know about this when it comes to symptoms. Let's talk about treatment. Whew. All right, let me take a breather real quick. Thank you. I mean, we're talking about SIADH and diabetes insipidus. You gotta drink water. Oh, thank you. You might also need to take a sip of water. All right. Let's talk about treatment. Before we talk about treatment, I want to remind you what's going on here. With diabetes insipidus, the problem is that this guy is not producing enough ADH. So again, when you don't produce enough of something, what do we do to fix it? We give it to you, okay? So diabetes insipidus is too little. We're going to fix it by replacing it, by giving it. So we have a synthetic form of ADH, which is also known as vasopressin or demopressin. We would usually give it to this patient. Sometimes this patient has to be on it lifelong, okay, depending on the cause of their diabetes insipidus, which I don't want to dive into too much, all right? And remember, they are also losing fluids. So we're just going to give them IV fluids to replace all the water they've lost, while also giving vasopressin to stop this old shenanigan and replace the ADH that they don't have enough of. All right. Now, moving on to our sister SIADH over here. This girl has too much ADH. She don't need no more. Instead, she needs us to take it away. She needs us to take out the excess that she's dealing with. So we're going to treat by removing. All right, we can either give diuretics because you have too much anti-diuretics. We will give diuretics to help pull out the excessive fluids, okay? But we often give diuretics only if the sodium is not less than 125. Remember, this patient also has low sodium. So if you give diuretics, sometimes it pulls out their sodium. So if the sodium level is still a bit up there, like 125-ish, anything less than that, we might not give diuretics just yet. Instead, we might replace the sodium first by giving some hypertonic solution. Remember, you should make sure seizure precaution is on deck. Then there's this medication called democlocycline or lithium carbonate that we can give to combat the action of the ADH. So it's like an antagonist that works against the production of ADH. All right. That is it on diabetes insipidus and syndrome of inappropriate antidiuretic hormone. But I can't go without giving you a quick summary to tie it up, right? So diabetes insipidus, once again, is underproduction of ADH. You got it. And syndrome of inappropriate antidiuretic hormone is what? Overproduction. Thank you. All right. And when you have a underproduction of something, it's too little, you replace it with vasopressin or demopressin. And you got too much of ADH over here, what you do is you reduce it. So we can give diuretics or we can give them a clocycline. And please don't ever forget, with the syndrome of inappropriate diuretic hormone, please watch out for, it starts with a letter S, it starts with letter S, it starts with letter S, I'm waiting for you to get it. Seizures, thank you, all right? And that is it, ladies and gentlemen. All right, everyone. I really hope that today's class was beneficial to you and you learned a thing or two. Once again, make sure if you are not subscribed, please subscribe. Please. And share this channel with some of your friends and colleagues, a family member you know needs it. Let them know, like, comment, and if there are any topics, any nursing content or problem area, please let me know. You can drop it in the comment section or you can shoot me an email at elvernursing@gmail.com and I will definitely attend to it. Thank you so much. I'll see you on the next one. God bless you.